Hi everyone, and welcome to our module on treatment of COPD and asthma. I'm going to start this module by talking about drugs that are used to treat both COPD and asthma, and then after that I'll move into special drugs that are only used for one condition or the other. So drugs used to treat both conditions include short-acting bronchodilators, and these are drugs like albuterol and ipratropium. We'll talk more about these in a minute. Also long-acting bronchodilators like salmeterol and formoterol, and drugs like tiotropium. And then finally, steroids are used to treat both conditions. Let's start by talking about the beta-2 agonists. Drugs in this class bind to beta-2 receptors in the lungs. That leads to the activation of adenylate cyclase and an increase in the intracellular level of cyclic AMP in smooth muscle cells. And recall that the sympathetic nervous system relaxes bronchiolar smooth muscle, causing bronchodilation to allow more air into the lungs as part of the fight or flight response. And that's what beta agonists do. They activate those beta receptors and they cause the bronchioles to open up so that there can be more airflow. Albuterol is a short-acting beta-2 agonist. This is very commonly used either as an inhaler or by a nebulizer for patients with asthma. Many patients with asthma take this during acute attacks as needed, which means PRN. Basically, anytime they feel that they are wheezy or short of breath, they can take a puff of their albuterol inhaler so that they can feel better. There are long-acting beta-2 agonists like salmeterol and formoterol, and importantly, these drugs are never used as monotherapy. They're always used together with inhaled corticosteroids, and that's because clinical trials of long-acting beta-2 agonists used alone as monotherapy have shown an increase in adverse events, and so for this reason, they're always given together with inhaled steroids. And then finally, you can have systemic side effects of these drugs if they're absorbed, although this is rare. The most common thing that patients develop is a tremor. Less commonly, patients develop palpitations or arrhythmias. And all of these things are the result of stimulating beta-1 and beta-2 receptors in the systemic circulation. Next class of bronchodilators we're going to discuss are the muscarinic antagonists. So recall that the parasympathetic system bronchoconstricts as part of the rest and digest phase. So these drugs are going to block the parasympathetic activity, and this will create bronchorelaxation and bronchodilation and allow more air to flow. So recall that the vagus nerve releases acetylcholine, and this causes bronchoconstriction, and this works through muscarinic receptors. So these drugs are going to block the muscarinic receptors on bronchial smooth muscle, and this is going to lead to bronchodilation. It's basically going to prevent bronchoconstriction. There's a short-acting muscarinic antagonist, and that's ipratropium, and then there's a long-acting one, and that's called tiotropium. And these drugs are generally well tolerated. There really aren't any important side effects you need to know about. Next class of drugs used for both COPD and asthma are the steroids. So there are inhaled corticosteroids like beclomethasone and fluticasone and budesonide. There are also oral drugs that come in pill form like prednisone. And then in the hospital, you'll often administer patients with asthma and COPD exacerbations Solumedrol, which is methylprednisolone, and that's an IV drug. For step one, they want you to know a little bit about the mechanism by which steroids knock down inflammation. Now, we don't completely understand this, but some of the things we do know are that steroids inhibit the synthesis of cytokines by binding to a glucocorticoid receptor inside cells, and this leads to many immunosuppressive effects. One thing that happens is there's decreased expression of many interleukins and other important mediators like interferon gamma, TNF alpha, and GM-CSF. In addition, steroids appear to inactivate NF-κB. NF-κB is nuclear factor kappa beta, and it's a transcription factor that induces the production of TNF alpha and probably some other important mediators. A side effect of steroids that you need to know about is oral candidiasis, which is called thrush. This is a picture of it right here. So candida doesn't grow in the mouth if you have a functioning immune system, but if you inhale steroids and some of it gets on your tongue or in your cheeks, you can get thrush, which is this white plaque stuff like here. It also happens in patients receiving chemotherapy sometimes. To avoid this, you tell asthma and COPD patients to rinse after they inhale their corticosteroid, and that will decrease the likelihood that they'll get thrush like this patient in the picture here. So all the drugs I discussed up to this point are used in both asthma and COPD, but now I'm going to talk about drugs that are only used in asthma. And the first group are the leukotriene receptor antagonists. So leukotrienes are very important chemical mediators of the asthma reaction, and many drugs block the production or action of leukotriene. So the first group are receptor antagonists, and these drugs are oral. They're taken as a pill, and the one that's most often used is montelukast, which is also called Singular. And this drug is useful in all forms of asthma, but it's especially useful in aspirin-sensitive asthma, which is a rare subtype of asthma that's triggered by taking aspirin. And these drugs are generally well tolerated, and they've become very popular for patients with refractory asthma. Another leukotriene drug is Xolutin. It's also oral. It's a 5-lipoxygenase inhibitor, and this blocks the conversion of arachidonic acid to leukotriene. So it's also going to block the effect of leukotrienes, but in this case, it's going to block the production of these mediators instead of the receptor antagonists, which just block their effects. So here's a slide showing the chemical synthesis of the eicosanoids, which are signaling molecules derived from fatty acids. And eicosanoids include leukotrienes and also prostaglandins and thromboxanes, but the leukotrienes are particularly important for asthma. So when a mast cell is stimulated, it will activate an enzyme called phospholipase A2, which will pull lipids from the cell membrane and synthesize arachidonic acid. From arachidonic acid, the leukotrienes can get synthesized via the enzyme lipoxygenase. So the two drugs we just talked about will interrupt this process. Xolutin will block lipoxygenase so that leukotrienes aren't produced in the first place. Montelukast, on the other hand, is a leukotriene D4 receptor antagonist, so it blocks the action of leukotriene D4. And leukotriene D4, it turns out, is a very potent bronchoconstrictor, and that's why blocking its receptor is effective for therapy in asthma. Next special asthma drug is omalizumab. This is given as a subcutaneous injection. It's an IgG monoclonal antibody, and it blocks the ability of IgE to bind to the IgE receptor on mast cells and basophils, and this interrupts the asthma reaction. And then another asthma drug is cromolyn, which is given by inhaler or nebulizer, and this inhibits mast cell degranulation, and it blocks the release of histamine and leukotrienes. This used to be a very popular asthma drug, but it's largely been replaced by Singular now. The next asthma drug we'll discuss is theophylline, and this is part of a group of compounds called methylxanthines, and caffeine is another example. Theophylline has multiple complex mechanisms that are not completely understood, but it definitely causes bronchodilation. It probably does this by inhibiting phosphodiesterase. This leads to less hydrolysis, which is the breakdown of cyclic AMP, and the net result is that you get more cyclic AMP, and recall that more cyclic AMP leads to bronchodilation. There also appear to be effects on the inflammatory cells. They get down-regulated in patients taking theophylline. Theophylline is really not used much anymore. It's a much older drug. It's kind of like the digoxin of lung disease. And the reason it's not used is because just like digoxin, it has a narrow therapeutic index. You have to monitor the levels, you have to titrate the dose, and the goal is to get a peak serum concentration of between 10 and 20 milligrams per deciliter in patients. Now, not only do you have to titrate the dose and monitor the levels, but theophylline is metabolized by P450, so there are lots of drug-drug interactions. Some common culprits that can lead to high theophylline levels and toxicity are cimetidine and ciprofloxacin, erythromycin, clarithromycin, also verapamil. All of these drugs have been associated with theophylline toxicity in patients by inhibiting the P450 metabolism of the drug. So let's talk about the clinical presentation of theophylline toxicity, and this is very high yield for your boards. So patients with toxic levels of theophylline first get GI toxicity, so they have nausea and vomiting, and then they get neurotoxicity, which are seizures. So the overdose scenario is nausea, vomiting, and seizures. The way I remember this is by remembering that theophylline is like caffeine. So you can imagine someone who took way too much caffeine, they would be sick to their stomach, and they would be shaking, which reminds me of the seizures. Use that if it helps you. That's how I've always remembered it. There is also cardiotoxicity associated with theophylline. It blocks adenosine receptors, and you can recall that adenosine slows the heart rate. So if you block those receptors, you get an increased heart rate, and you can also get arrhythmias like atrial tachycardia and atrial flutter. Patients who die from theophylline overdose or poisoning die from arrhythmias related to the cardiotoxicity. Another special clinical scenario to know about is a patient on theophylline for asthma or COPD who comes in with a supraventricular tachycardia. We often administer adenosine to try and slow the heart rate and break the tachycardia, but this won't work in the patient on theophylline because the theophylline blocks the adenosine receptor. In real life, this is an extremely rare clinical scenario, but they love to ask you this on board, so make sure you know that patients on theophylline, adenosine will not work. So here's my summary slide for the therapies for asthma. So first off, asthma is often triggered by antigens, and if you can identify those antigens, you can tell patients to avoid them and they won't get asthma. So patients with asthma should avoid secondhand smoke and dusty settings. All these things can trigger the condition. Once the condition gets started, this sequence begins, and you can try to block it with different drugs. Omalizumab is going to block IgE from stimulating mast cells, and that's going to dial down this process. Steroids, Xolutin, and cromolyn are all going to interfere with mast cell release of chemical mediators like leukotrienes and histamine. Once these mediators are out there, you can give drugs that block their effects like bronchoconstriction, and these include the beta agonist, the muscarinic antagonists, theophylline, and the leukotriene receptor antagonists. So now let's talk about special drugs used to treat COPD. So first off, you should know that theophylline can be used to treat COPD in addition to asthma. And then the one special COPD drug you should know about is called roflumilast. It's an oral drug, and it's a phosphodiesterase 4 inhibitor, and this decreases inflammation. It also appears that the drug may relax airway smooth muscle, which also helps. So now that I've gone through all the different drugs used for asthma and COPD, let me talk about how you treat the conditions in actual practice. So the first thing to know is that both asthma and COPD have acute exacerbations, which are treated one way, and also chronic therapy to suppress the condition. So we'll talk about those separately. So patients who have COPD and develop acute exacerbations are usually administered oxygen to bring up their oxygen level. This is obvious. They're often given nebulized albuterol and ipratropium together. This is called Combivent, and it's a very effective therapy for COPD. Then they're given steroids, usually very high dosages, either prednisone 60 milligrams orally or methylprednisolone 80 milligrams IV every 8 hours. And then for patients who have COPD exacerbations that are severe and require hospitalization, they're given antibiotics. These have been shown to be effective, so even though you may not see a pneumonia on the chest x-ray or they may not have a fever, they're given antibiotics anyway. The antibiotics we usually choose are fluoroquinolones or amoxicillin and clavulanate. These two have been shown to be effective in reducing the severity and adverse outcomes from acute COPD exacerbations. Once the patient gets over their acute exacerbation, you treat them long-term for chronic disease using the GOLD criteria. So GOLD stands for Global Initiative for Chronic Obstructive Lung Disease. And the GOLD criteria classifies COPD as mild, moderate, severe, or very severe, all based on the FEV1. Recall that in pulmonary function tests, the FEV1 gets low in patients with COPD and obstructive lung disease. So if the FEV1 is greater than 80% of predicted, this is GOLD stage 1, which is mild, and it goes all the way down to GOLD stage 4 when the FEV1 gets under 30. GOLD stage 2 and 3 are in between. So once you determine the stage, you then give therapy according to that stage. So whether they're mild, moderate, severe, or very severe, you give therapy in a stepwise fashion by adding therapy based on the severity. So mild disease patients get an as-needed short-acting bronchodilator. Usually they just use as-needed ipratropium. When the disease becomes moderate, you add a long-acting bronchodilator, usually tiotropium. Severe patients get inhaled corticosteroid, and then very severe patients are administered oxygen and sometimes have surgery. We'll talk more about surgery in a minute. And then these very severe or refractory disease patients can also be given theophylline or roflumilast if indicated. A couple of other things about treating chronic COPD. Oxygen has been associated with increased survival, so it's very important to give oxygen to patients who need it. It's indicated when the PaO2 falls below 55 or the room air O2 sat falls below 88. Another comment I'll make is on pulmonary rehabilitation. This is a structured exercise program for patients with lung disease, and this has been shown to improve exercise capacity and quality of life and decrease dyspnea. It's a very effective treatment for patients with COPD. All patients with COPD need to be vaccinated, and then smoking cessation is, of course, very, very important to improve outcomes in this disease. So now let's switch gears and talk about asthma. Patients with asthma who develop an acute exacerbation are treated with oxygen, just like COPD patients. Asthma patients are generally given nebulized albuterol because albuterol alone is effective for controlling the symptoms. These patients are treated with steroids, just like COPD, so IV or oral steroids, either prednisone or methylprednisolone. And then rarely in asthma patients who are very sick, sometimes ipratropium is added, and sometimes IV magnesium sulfate is given. This is a bronchodilator through an unclear mechanism. It's thought that it maybe blocks calcium influx into bronchial smooth muscle, but whatever the mechanism, it has some benefit. And like I said, patients who are very sick are sometimes given these drugs. Just like with COPD, asthma is treated with a step therapy. However, with asthma, you don't have a number like the FEV1 to follow because patients with asthma return to normal between episodes, so they don't have a reduced FEV1 that you can use to guide therapy. So in asthma, you pick your therapy just based on symptom control. You want the patient to have relatively few or 0 episodes of asthma per week. So for step 1 patients who have mild symptoms, usually just give them albuterol as needed. That's a short-acting beta agonist. Patients who continue to have symptoms despite using PRN albuterol, you add a low-dose inhaled corticosteroid. If the symptoms get worse, you can then go up to a medium-dose inhaled corticosteroid or also add a long-acting beta agonist. Step 4 patients get a medium inhaled corticosteroid plus a long-acting beta agonist. Then you can move all the way up to high-dose inhaled corticosteroids And then finally, patients at step 6 usually need oral steroids to knock down the inflammation. As you're moving up these steps, you can add any of these drugs down here to try and minimize the patient's need for their inhaled corticosteroid and their beta agonist. And as I said before, Singular, the leukotriene receptor antagonist, is something that's commonly used here because it's an oral pill and it's generally well tolerated. Finally, let me discuss surgical treatment. This is for advanced or end-stage COPD. What you want to do in this operation is reduce the lung volume by either cutting out part of the lung or by removing bulla that have been created by emphysema. What you're trying to do is take out the diseased lung tissue, and this gives more room for the healthy lung tissue to expand, and this can improve symptoms in select patients. Another surgical option for COPD is lung transplant. The problem with this is most COPD patients are elderly and they're smokers, so they often have concomitant heart and kidney disease, and this makes them poor candidates for lung transplant. But if they're on the younger side and the rest of their body is relatively healthy, they may be able to tolerate the operation to transplant their lungs and the immunosuppressive therapy afterwards. And that concludes our module on the treatment of COPD and asthma.